Okay, Don, thank you for coming to help me out here. I just wanted you to have a look at this OCT as well and tell me if I've got everything correct and if we're heading in the right direction.
Acquiring the images and reading the images.
So I've been practicing for about a month now.
About a month, okay.
So just having a hands-on training in the department.
Right. Are you quite comfortable reading the glaucoma OCTs, or?
I'm not. I've only had a month's experience.
Okay.
So yeah, but I think I'm doing fairly well for for the amount of time that I've had to do it. I can have a look at a scan and say this is typical for glaucoma or this is not typical for glaucoma.
100%. So I think what we'll do today is I'm just going to quickly run through the reading of a glaucoma scan without talking.
Yes.
Okay. Then I'll do the same while I'm talking.
Yeah.
And then I'm going to ask you to just run us through the reporting of a glaucoma scan. Describe what you are doing while you are looking at the left eye, and then you can just do silent reporting on the right eye. At the end, I may just ask you to think what you think of this case in total, what the final diagnosis is on this case, whether it is glaucoma or not, and maybe which eye is worse. Right, and then at the end we'll just put it all together and see what you think of it.
Perfect.
Right. Okay, so after looking at the right eye, I'm now going to look at the left eye. So there's a line scan, and it looks pretty normal. So Jonathan, I'm going to just ask you now to also read the glaucoma scan, the same scan. I'm going to ask you to tell me what you're doing when you are looking at the right eye, and then you can just do basically silent
just
evaluation on the left eye. At the end of looking at the images on the right eye, I'm going to ask you your opinion on the right eye, and at the end of looking at the scan on the left-hand side, we're going to ask you just to give your overall opinion on what your findings are in this specific case.
Okay, so first thing we're going to do, we're going to identify the patient in the date of the scan. So this is, she was born, and this is a OCT that was done on the. This is the correct scan that we're looking at. First we're going to have a look at the line scan in the posterior pole. So we're going to just have a broad look at the line scan. The line scan in the posterior pole looks normal. I don't see any macular edema or subretinal fluid or anything that would confuse our results.
I agree.
So moving on to the BMO analysis, Brooks membrane opening analysis. So we're going to have a quick run through the BMO rim analysis and look for any obvious errors. So if you see here is an error in measurement which needs to be corrected. You'll notice it on the spike in the graph, and also when you're running through you'll notice it because the arrow is in the wrong place. So it's important to check every part of every slice in the BMO rim width. So let's go quickly.
Good.
Alright, so that's been corrected.
Excellent.
So, yeah, there we go. A quick run through the DMO analysis. We're going to go to retinal nerve fiber layer thickness and look at the circular scan. Oh, before I forgot to mention, while we're on the DMO rim analysis, what we're looking for specifically in glaucoma is supratemporal and infratemporal thinning. And on this patient, you can see here there's global thinning, but it does seem to be concentrated around supratemporal and infratemporal areas. The retinal nerve fiber layer thickness, once again, we're going to have a quick run through here and just make sure that there's no errors in measurement. This patient's scan looks accurate. And then we're going to look at the inner slice, the middle slice, and the outer slice, and we're going to look at the pattern of thinning. Starting at the inner slice, this patient has got supratemporal and infratemporal and infranasal thinning. The middle slice patient has significant thinning on the supratemporal and infratemporal regions, and also moderate thinning in the other regions. And then in the outer slice, also supratemporal and infratemporal thinning.
Alright, so tell me what you think.
So my overall impression of this patient is that this patient has a mild to moderate glaucomatous change, not as severe as in the right eye.
Great.
The reason I'm saying that is because there's less significant hemisphere asymmetry. It still is present, but it is less significant than the other side. There was some infratemporal thinning on the BMO, a retinal nerve fiber layer analysis. And we're looking at the thickness map of the ganglion cell layer. We can see that while there still is a temporal channel which suggests glaucomatous change, and we have a typical nautilus shell pattern on the ganglion cell layer, the inferior thinning is not as pronounced as on the other eye. Also, when looking at the progression maps, the thickness of the retinal nerve fiber layer was not as pronounced as in the other eye. So this is still a patient who I would be suspicious of a glaucomatous change, but not as severe as in the other eye.
Great. So our time was cut short a little bit. So today we'll basically do a bit of a debrief on what we did the last time at the hospital.
Sure.
So, unfortunately, you did such a good job during the demonstration of your skill that there isn't really much that I could fault there. Okay. So I actually left out identifying the patient and saying what day it was done and so forth, which you did. So it's actually a mistake that I made. But you followed the protocol of reading a glaucoma scan, and you came to the correct diagnosis. Okay. So the question really now is how we move forward, because you have now basically reached a basic competence of reading glaucoma scans, but maybe not at an expert level, because as you know, there are many confounding factors. One of them, of course, the swelling of the retina that you get with some conditions, but as you know, glaucoma is not the only thing that can cause optic disc atrophy. So there are a whole lot of other optic neuropathies that can mimic the same endpoint. And one of the most important things that we must distinguish is whether a patient has glaucoma or demyelinating
disease or optic nerve atrophy of some other neurological cause, which will immediately take you away from the glaucoma management into management of a neurological disorder, such as multiple sclerosis, such as brain masses, etc. So the next step that I want you to take is to learn how to distinguish a glaucoma scan from a multiple sclerosis scan, where the multiple sclerosis has already caused optic nerve atrophy, because clinically they will look pretty much the same, all right? So do you perhaps know what the difference is?
So looking at, looking at a glaucoma scan,
Right.
In order to distinguish glaucoma, the typical changes for glaucoma versus other similar presentations, what I would expect is, if you're looking at a patient with glaucoma, you would expect to see a number of different congruent changes throughout the various parts of the retina. So if, for example, we see thinning of the BMO rim, but no typical ganglion cell layer changes and no typical retinal nerve fiber layer changes, this would lead me to think perhaps this is not glaucoma, perhaps we're dealing with something else.
Okay. Right. And do you perhaps know how multiple sclerosis shows up on an OCT? So chronic relapsing multiple sclerosis, where you already have optic nerve atrophy. Do you perhaps know the difference between how they present versus glaucoma? I'm not expecting you to know this.
I don't. I'm aware that multiple sclerosis is a demyelinating disease.
Correct.
So my expectation is to see atrophy of the optic nerve head.
That's
and
correct.
thinning of the BMO rim. But other than that, I'm not sure.
Yeah. So that is going to be then the next step in your kind of evolution towards expertise in reading a glaucoma scan, to distinguish between glaucoma and demyelinating disease. And we have a few OCTs of patients with look at the doggies also visiting. Yeah. So we'll show you some. I'll get a mash-up between glaucoma scans and multiple sclerosis scans without telling you which is which.
Right.
And then I'm going to ask you to look for specific changes that are going to distinguish these two from each other.
Right.
All right. So basically, what I'm going to expect from you going forward is, when you look at your glaucoma scans, just think how you're going to distinguish between glaucoma and multiple sclerosis or other optic neuropathies and neurological disorders. Okay, and specifically I'm going to ask you to look at the inner nuclear layer. All right. So I've explained to you before how deliberate practice works. All right, and maybe before we just go into that, just give me a brief summary of how you are practicing your OCTs at the moment. Glaucoma or other OCTs, how you are going about practicing learning how to do OCTs.
Okay. All right. So essentially, because I've had very little formal training, training has been on the job, and I would be looking at scans both individually and in consultation with my colleagues, and then they would be giving me feedback on specific points. So, for example, if this is a patient that we're looking for a progression of glaucoma or something that I'm very comfortable in,
Right.
I would have a look at the scan, and if there's something on that scan that is not typical or that I'm unsure about,
Right.
I'll go to one of my colleagues, one of the registrars or one of the consultants,
Mhm.
and I'd just say, please, could you give me some feedback on this and let me know what you think. And so essentially, there's a sort of a self-initiated identification of an unclear area, which
Cool.
then gets
Great. Yeah, that's exactly how you should do it, and you should seek immediate feedback
yes.
whenever you can. So
Yeah.
what we typically suggest is while the patient is sitting on the other side of the OCT, so you've just acquired the images, you've now read your OCT, and you see a problem, then go and call somebody to assist you, because sometimes it's necessary to take some other images or very specific, or hone in on very specific areas, and then you can do it while the patient is there. So great, that is exactly what we expect you to do. So obviously continue with that, but just remember, like athletes or pianists, I can give you an example. When I did pole vaulting, a lot of the stuff we had to practice, we practiced in a swimming pool, okay, just to get the just to practice a very specific movement.
Yeah.
Similar with pianists, they will practice a certain bar, which is difficult, or certain few bars, and concentrate on that until they've got that done. And myself who play the keyboard, it's more difficult on the piano to play stuff, but I teach myself on the piano, and then I go back to my keyboard, where it's quite a bit easier to play fast riffs. So what I'm trying to say is that you must try and also find different ways of learning specific skills related to glaucoma or other OCTs. And the one thing that I can strongly suggest is that when you look at specific layers in the OCT, say now you're in a nuclear layer where you're going to look for microcysts. On the spectralis that we have these images basically in, call it black and white or monochrome, whatever you want to call it. Probably black and white is the better, or grayscale. Sorry, grayscale is the term. But we have colleagues in private, like Dr. Deseto, who has he's got a TopCon OCT. So what I would suggest is that you make contact with him and just ask him if you can maybe look at a few of his scans, and his glaucoma scans, and his multiple sclerosis scans, and just see how it looks different, how the same pathology will look different on a different OCT. It just really helps you to build your expertise by looking at things from another perspective or with another instrument, can one say. All right. So just to summarize, you have a very good grasp of the basic reading of the glaucoma scan. The next step is now to distinguish it from neurological or other optic neuropathies, and these conditions can sometimes be conditions that can cause a great deal of morbidity, if not mortality, all right, which make them so important. And thirdly, just try and find innovative ways to look at specific parts of the OCT, because these can also help you build your expertise. All right. Is there anything that is not clear? Is there anything you wanted to ask or add?
I think
Because you're welcome to do so.
I think that pretty much sums it up.
Okay. Great. Yeah. No, well, continue doing what you are doing and just follow these new tips, and then in about 3 to 4 weeks I'll give you that those 10 patients, and then we'll see how you are progressing on the path towards expertise in reading glaucoma and other OCTs. All right.
Lovely. Thank you very much.
Right.